Professor Tobias Banaschewski, thank you so much for joining me with ESCAP today, the Maastricht Congress, where you'll be giving a keynote talk on pharmacotherapy in disruptive disorders. It's quite a broad title, so can you give us just a little bit more of information about what you're going to be presenting to us?
Yeah, thank you so much first for inviting me to the Congress, and I'm very happy to give a brief overview. Pharmacotherapy is just one possible intervention or set of interventions into the treatment of disruptive behaviors. And I will, of course, give a little bit an overview about the possibilities that we have to treat children and adolescents with disruptive behavior disorders, which in particular refers to ADHD, oppositional defiant disorder, and conduct disorder. And I will present the treatment algorithms and also elucidate a little bit the rationale that's behind those algorithms. And algorithms always are for the majority of the cases, not for all children, of course. And I will also outline certain flaws and traps that we should avoid if we want to improve the treatment of these children.
Okay, great. So you're going to speak a lot about delivering that treatment and how to. What about actually before we give treatment? What about the early interventions? What can we do there?
You mentioned a very important point. Better to prevent than to treat, that's always true. And we are not particularly good in identifying the children at risk for the development of those disorders at the current moment in time. This is due to a variety of factors. The child psychiatrist can only identify a child if he meets or sees the child, obviously. And oppositional defiant disorder as well as ADHD do occur quite early. So what we need to do is to improve the interaction of the mental health service with the education system. Nurses in kindergarten or teachers in school, they need to have a much more knowledge about which children might be at risk or might already be developing first symptoms. And they should also learn more about the way how to build up, let's say, resilience in these children, or to at least reduce the risks by if they interact with these children. And so I will also speak a little bit about the underlying causes, what we know for these disorders, because there are opportunities for prevention. We don't know as much for ADHD, how to prevent ADHD, but we surely know a lot about how to prevent the development of conduct disorder, for example.
So yeah, you've mentioned exactly about healthcare professionals, and it's not just the psychiatrist, it's the system as a whole. And obviously across Europe we have various different countries that are dealing with different strategies, so and obviously problems. What can you offer to those psychiatrists and those health professions across Europe in those different settings?
Obviously we need to improve identification, and this depends on the specific system. It makes a huge difference whether you're living in Greece, or whether you're living in Germany, or whether you're living in the UK. There are factors of the system, but there are also factors that child psychiatrists can change in order to improve the prevention and, for example, of secondary conduct disorder, or improve the treatment of disruptive behavior disorders as a whole. And this is to stick more to guidelines. Guidelines obviously are only helpful for the majority of cases, as I said, but there are certain key recommendations that should not be overseen. I think this refers, for example, to the specific question when to medicate, whether to medicate, and in which way, with what type of medication we should medicate which children at what age and with which specific symptoms. What do I mean by this? For example, emotional dysregulation is a very frequently associated feature in ADHD, but also in ODD. There is a 90% overlap with ODD. You could even call it a core symptom. Now, emotional dysregulation is what we call emotional dysregulation, or a lacking capacity of emotional regulation, can obviously stem from various factors. And but the main point that should be clear is that this is not particular motivation problem, but rather a capacity or skill problem. Now, if this is true, what does follow from this? From this, it follows that we need to improve the skills of the children and not just work on the consequence side of behaviors, for example, by introducing response cost systems. Rather, it's much better to work on the antecedent side and not to let the child run into a problematic situation when it becomes irritable. We know this, by the way. You would not, if you are in a bad mood already, or if you have slept not very well, you would lower your demands, and you would be kind of flexible in your parenting behavior. Therefore, parenting training is obviously one of the core elements. And what also the topic of my lecture will be about the pharmacotherapy of disruptive behavior disorders. I have to say that in relation to ODD, without ADHD, pharmacotherapy or medication is very rarely the first option of and we should as child psychiatrists always try to go for a multi-modal assessment and try to reduce pharmacotherapy but use it if necessary. It's probably necessary if there are really very intense disruptions or explosive, very extensive explosive behavior. But even then, pharmacotherapy should only be given for a certain time. It's never a good strategy to go for pharmacotherapy as first instance, as first-line treatment. And there is a lot of mess done in our countries, in Europe, but even more so in the US, when children aged 3 are medicated with polypharmacotherapy, and some children actually died from this approaches. And this has to do with the conceptualization of how to understand oppositional defiant disorders and conduct disorders. And these are disorders related to the relationship between the child and the parent, or between two people. And this relationship cannot be completely be assessed without assessing the environment without assessing the interaction. So we need to take a systemic approach in the diagnosis, and also if we try to break the vicious cycles. In this respect, I would say psychoeducation is a mainstay, but it always depends what type of psychoeducation. What should we tell the parents? Mm-hmm. And then if pharmacotherapy is needed, we can go different routes, be it for ADHD. Then if there's ADHD, it may make sense to use stimulants, which also have or atomoxetine, which also have a good effect on emotion regulation capacities. But if there is no ADHD, we should go for psychotherapeutical interventions first.
Okay, I think we'll leave it there. You've spoken already on some very key points. So thank you so much for speaking to me, and we're really looking forward to seeing you in person in Maastricht. Thank you so much.
Thank you.